So, as we are now assembled, we are a small and select group today, which is unusual. Our recent meetings have been sort of upwards of 40 and 50 people, so it's actually quite nice to have a slightly more intimate approach today. That's great. First and foremost, I wanted to just say a huge welcome and thank you for stepping into the room today. I'm very, very aware that, especially if you're here for the first time, it can be a very daunting step to take. And we all remember the first meeting that we came to and kind of acknowledge that. Just so that we are able to recognise where each other are at in terms of sort of meeting attendance. If you wouldn't mind just raising your hand if you're here for the first time, would be helpful for people around the room. Thank you. Thank you. And I know that we've got people here also who've been members for years and years, so welcome one and all. I want, if I can, just to obviously reiterate to anybody who doesn't know that I'm Jill Walton and I help to coordinate the groups. More importantly is that you recognise Emily and Hugh, if you could just give us a wave, so that if there's anything, you probably have had email correspondence from Emily and or Hugh in preparation for today, so thank you both. And by way of introductions, I want to introduce Susie Henley, Dr. Susie Henley, who is a clinical and research psychologist who's joining us for our discussion this morning. And in a moment, we'll also be joined by Dr. Jonathan Rohrer, who's a consultant neurologist, who's also going to join us until 12 to help host a sort of question and answer stroke discussion type of morning session. Alongside that, let me just issue a few housekeeping notices, and as always we say there's no fire alarms, so if the fire bells ring we have to meet in the courtyard through which you came via the fire exits and into the courtyard. The toilets, best really to go through the corridor, out of those doors, along the corridor, and the toilets are on your right in the main refectory. That's probably the easiest way where to head. And the other housekeeping notice is to say that all the refreshments will be provided here within the room, so hopefully we provide an hour for lunch. Lunch will be provided, and we really hope to kind of use that time to facilitate our sort of discussions and getting to share our story in a more sort of intimate way with one another. The only notice really that I wanted to push today was this one, and it's about a course that UCL, colleagues actually at UCL have recently developed. The first run of this course has just come to an end, and over 8,500 people signed up and did the course. It's been so popular that we're actually looking to run the course again in July and then again later in the autumn. And the reason that I flag it up today is because the first module is dedicated, or the second module is dedicated entirely to behavioural variant FTD, and it's a really useful resource and learning tool, not just for ourselves but to roll out more widely to those professionals and other people that you're in touch with who could do to know a little bit more about this diagnosis. So use the course to promote awareness of the diagnosis that you're trying to manage. There are flyers on the table for you to take away if you so wish, or email any of us for information about that course. It's free, it's online, and it's roughly 2 hours a week over 4 weeks. And you can dip in and out of it as you wish, and you can access additional information if you want to. So it really does kind of tick a lot of boxes. Yes, it actually covers from professional to lay person, and indeed person with a diagnosis, because you can choose how much further detail you go into. So you can take the course as it stands, or you can access the links and delve as medically or as scientifically as you want. Thank you, good question. And so this is the slide that we begin our support group meetings with and usually end them with too. And it is increasingly difficult to have our small group discussions in the way that we used to when the group was in its infancy. I'm conscious that we don't each have a time to introduce ourselves or to share our circumstances in the group environment. What I really hope is that by the end of today you will feel that you have shared as much of your story as you want to with somebody, and that you realise your story is hugely important and critical and vital, of course, for others to understand. I hope that today is helpful. If there's anything that requires clarification or sort of further information when you leave at the end of today, please don't hesitate to email or to phone, and we'll follow up in whatever way is most helpful. So with this in mind, and with the kind of respect and privacy for all that we hear and share within the rooms, the walls of this room today, I want us to move on, if we can, into what we build as a question and answer, but also a discussion type of morning session. So we've got the expert knowledge of Susie and John when he arrives to throw into the pot, but actually the real experts in the room, forgive me for saying, Susie, are actually you, and a lot of what you share amongst your own conversation is as valuable as anything that you ever hear from the front. We don't have microphones to hold the Q&A sort of session with, so if you can speak loudly, and we also will respond loudly, and the session we will record as we do all our presentations, and if it flows well enough, we'll upload it onto the website for you to access thereafter, but it depends a little bit on how discussion follows and what we feel is appropriate at the end of the day. So thank you, and as I say, we'll sort of host questions as you feel you'd like to throw them or share. It's not me that you need to hear, it's Ione. So I'm really thrilled to have Ione with us this afternoon. I think you've probably dashed from a lumbar puncture clinic and is dashing off to a lumbar puncture clinic and has kind of squeezed us in the middle of a very busy clinical sort of day. So without further ado, let me hand over. Ione is a colleague from the Dementia Research Centre at UCL and works alongside John, who was here this morning, and a team of scientists, clinicians and researchers with an FTD interest. So thank you, Ione.
Thanks, Jill.
We might need to fiddle with feedback, so we'll just see.
So I'm a neurology registrar, but I'm also doing a PhD at UCL looking into the cause of FTD. And as part of this research, my project's actually looking at spinal fluid. So I do a lot of lumbar punctures, not only for that, but also as I do the lumbar puncture clinic, which some people's relatives or some people here might have had a lumbar puncture on the Thursday morning at the National Hospital. And I became aware that a lot of people had a lot of anxiety or didn't know much about the procedure, and also some people were interested when they were asked whether they wanted to have one for research, why bother doing one given it was an invasive procedure. So what I'm going to talk a bit about today is what is it, why we use lumbar punctures to diagnose certain types of dementia and why they're not useful for other types, and a little bit about how we use it in research and why spinal fluid is so interesting to us as scientists and as doctors. And I'll put some time in for questions as we go along, so do feel free, once I've said if there are any questions, to ask some, but there's also some time at the end, so hopefully it wouldn't go right up to 2 o'clock. So before we start, has anyone here had experience of someone who's their relative or a friend who's had a lumbar puncture? So quite a few of you. And can I ask, it's going to be a little bit of an interactive talk, so was anyone surprised at how it took place, or has anyone got any comments about what they felt when they actually came to have it or watched their friend have it? Yeah. That is extremely rare, so I'll talk about some of the side effects if you want while we go through. So most of the time it's quite an easy procedure to do, it's a very safe procedure to do, and the vast majority of people don't get any pain or side effects afterwards. So I'm sorry she had that experience, but it is unusual. Yeah, sometimes if people have had several attempts during it, then it can cause more puncture of the layers we're going through, so it possibly could, but it's not clearly understood why some people get side effects and others. So we'll come on to that. Anyone else had a positive experience of lumbar punctures? That's all right. No, it's good because lots of people do hear these stories. So. Yeah. So I think a lot of people have heard stories either on the internet forums or people who've had lumbar punctures as a younger person, often in the context of meningitis, so when they're generally unwell and it has to be done, and obviously it's uncomfortable and they're unwell, they've got a headache, they're vomiting because of that illness, so there's a lot of association with that. So what I thought I'd do is just take you through what the actual procedure is. So for some people who might have relatives who haven't had one, or perhaps you can spread the word to other people, contacts or friends who might need to have one in the future, because I think knowledge means that it lessens anxiety. Once you know what's going to happen, some people find that helpful. So I'm going to talk a bit about why we do them, just in terms of why we actually want to look at the fluid. How we actually do it, I'm going to have step-by-step guide, so hopefully by this point you might be able to do it yourself. And a bit of, that's not a recommendation. The needles have changed, they've got thinner and better, yeah, so that is much of an improvement. And a bit of advice about if someone's going for lumbar puncture, what to do before and after. So, the reason that spinal fluid is important is that our brain and our spinal cord float and are supported by a column of clear fluid that is in continuity. So fluid is produced by a little bit of blood vessels called the choroid plexus in the spaces, so the ventricles in the brain, which is kind of gaps in the middle of the brain. And it's always continuously being produced at a slow rate, which helps obviously when we've taken some out, because you make it again quite quickly. And it nourishes the brain, it cleanses the brain, and it maintains a support for the brain's actual structure. So it's very helpful for us to know what's going on with that, because we can measure the pressure of it to see if it's too low or often too high in some conditions, not usually dementia. We can look at the constituents of it, so that the proteins and the sugars in it, and see if they're normal or abnormal. And we can also tell if there's an infection in it. So for example, if someone's got meningitis, we want to know what bug or which bacterium is there, so we can give them the right treatment for that. So I'll talk a little bit more about those points in a minute, but that's basically what we're aiming to do, is collect a small sample to send off to a laboratory. And the reason why it's called a lumbar puncture is that we go in through the lumbar, the lower part of the back, and obviously punctures, relatively self-explanatory. But the way we access it is between the backbones, between the vertebrae, because there is a way between them to get into the space at the bottom there and get into the fluid. So we're not taking it from the brain, because that would be dangerous. We're taking it from the spinal area below where the spinal cord finishes. So there's a big space of fluid below where the spinal cord is. We wouldn't want to go in higher, because we'd hit the spinal cord and that would be problematic. But we then can collect a small amount of fluid, usually only 5 or 10 millilitres, to send off. So as I said, it gives us a window into the brain's function, how it's functioning, and if there are any problems with that. And dementia obviously is a problem with the brain. It's a disease. It's an umbrella term. I'll talk a bit more about that later on. So specifically, the conditions we do them other than the dementia are if someone's thought to have a sudden infection of the brain or the brain's linings called meningitis or encephalitis. If there's a kind of process that might be ongoing, like multiple sclerosis, and we want to look for inflammation, so when the immune system is very overactive in the brain. When brain cells are starting to die prematurely in dementia, we want to see whether we can show evidence of that. And then other conditions such as a sudden bleed in the brain, a specific type of bleed called a subarachnoid hemorrhage can be detected. And then, as I mentioned or alluded to, some patients have headaches. Vast majority of people don't have this type. But if the pressure is very high, often in young women, some people who are slightly overweight, it's more common, and that's called idiopathic intracranial hypertension, and we can diagnose and treat that condition with this procedure. So as well as treating these headaches, which are quite rare, if patients have cancer, and particularly blood cancers like lymphoma that affect the brain, very rarely we can use that route to give chemicals into the spinal space that floats up into the brain and treats it where we need it. But we don't do that in dementia at the moment. We don't have any treatments that are used like that. We're just collecting fluid. We're not inserting anything into that space. Some people say, well, is it like an epidural? Because lots of people obviously may have had one. It is similar, but we go into a slightly different space. We don't inject any anaesthetic into that space, so we don't get numb legs, because that would be bad. We are wanting to take fluid out. So I might just move straight on to how we do it, and then if there's any questions that arise, please do ask. So obviously we're aiming for the lumbar region, and the key thing is we're going in pretty much, when I say blind, I don't mean blind, but we are literally going in by feeling where we are, because as doctors we're taught to know what's called the landmarks, so the places on the back that we need to aim for. And The way we usually do this, and I personally use this approach, is we have to get the patient in a position where the backbones are slightly separating out, so there's space between them. Because if someone's standing up, we're quite well made, they're kind of quite interfitting, so we're kind of like dominoes next to each other. What we need to do is open that up, and one way that happens is if you bend forward, feel that they open up. So patients are asked to lie, usually on their left side, because most clinicians are right-handed, it's just easier that way, and bring their knees up to their chest, which opens up the spaces. And this is just a schematic diagram here, so showing that we go between the backbones, which are these white blobs on the right, through a few layers of skin, fat, tissue into that space, and then the fluid drips out of its own accord. So that's the lying down position on the left. Sometimes clinicians, so I don't know if anyone's met Dr. Patterson, he's a Scottish gentleman who does all the lumbar punctures usually on a Thursday. He prefers to get people sitting forward. It's just person's preference. I prefer to have people lying flat because it's more comfortable. If you're hunching forward for all that time, it can be a bit uncomfortable. So after someone's got into position, positioning takes a bit of time, we are setting up the field so it's as sterile and clean as possible. This person's not wearing gloves, which is fine at this stage, but after that we wear special sterile gloves. So we feel down the backbones looking for a particular level called lumbar 3 or lumbar 4, that's the number of the vertebra, to feel the space. And actually the level of the hips, if you feel the top of your hips here, that is the L4, the lumbar 4. So we go either just above that or just below that. Once we've felt the right space, some people make a little mark on the skin, sometimes people just know and they re-feel each time. We then need to clean it, so we used to use iodine. I don't know if you remember seeing those swabs on surgical programs, but we often use another thing called chlorhexidine to clean the whole back in that area. We then use local anaesthetic, which is a chemical in a syringe that numbs the area of the back, so just the skin and the fatty tissue and the ligaments, because it's actually, without that, much more painful. This is the worst bit of the procedure. I always tell people this, because you are going in with a needle through the skin and you're injecting local anaesthetic, which can sting a bit. So it's like going to the dentist and having an injection, but actually less tender because it's in the back. So it's like having a blood test, this bit, but we're not actually taking any blood out. After about a minute or two, that anaesthetic starts to numb the skin, and then we use the lumbar puncture needle, which is very thin, and it's about that long, and the reason it's that long is that people are different sizes and we have to sometimes go through quite a lot of fatty tissue to get into the right space. So person's lying down, we then re-feel and we go in with a needle, and we can actually feel a little give as it goes through the right ligament. We keep checking each time, and then we can feel the fluid coming out and we can see it coming out. So I was always really surprised when I first saw this. It's clear, it's completely colourless. Should be, if someone's not unwell. It's clearer than water. It's like Evian water. Literally, it's very clear. And it just drips out very slowly, probably over about 10 to 20 minutes, depending on how much you need to collect, into the bottle. We then take the needle out, put a little dressing on, and that's it. It's done. Does that make sense? Are there any questions about that? Not really, no. I mean, we tend to have a certain volume of fluid, whatever process is going on, and that's particularly not, it doesn't decrease over time, no. What does change it is if someone has dehydrated. So I can tell if people haven't had enough water on the day, because but everyone has different rates of fluid production. Yes, yeah. So often, sometimes you have a nurse assisting you, they can pass you it and hold it, but I tend to like holding it because I like knowing how much is there, I can see how it's going. Occasionally, we don't do this for dementia, but in patients who we think might have a high pressure, we can actually measure the pressure. So if you remember the old school manometers, like a barometer, you attach that and the fluid just rises up that and it gets to a certain pressure, and then we collect that fluid. If we applied negative pressure, so sucking on that, because the column of fluid is linked to the brain, we could pull the brain down and damage the brain at the base of the skull. So we wouldn't want to exert it would take much less time, but we definitely wouldn't want to suck anything out. So that's why we have to let it drip out. But good question. So After the procedure, we ask patients to lie flat, or as flat as they can, for about an hour. Now, it used to be 4 hours, but there's been studies on this, and the reason we do this is to reduce the risk of a headache, which I'll talk a bit about in a minute, which is quite rare in itself, but we used to make patients lie flat for 4 hours. Then there was a study showing that actually it doesn't really need to be more than an hour, and in fact some people say that actually there's no evidence that even an hour makes any difference. But it would seem sensible, if you've had a massive needle shoved into your spine, that you'd want to rest, and actually some people still say, you know, actually I got up too soon and I've had several lumbar punctures, and the time I moved around a lot afterwards seemed to bring on a slight headache. So I think we'd normally advise people to lie flat for an hour, and then they can get up, move around and do what they normally do, apart from avoiding strenuous exercise for 24 hours, and I'll talk a bit about that in the advice bit. So recap, positioning is everything. We feel down the spine, we clean the back so everything, we don't want to introduce any infection into the spine or the spinal cord. We inject the anaesthetic, then we use a longer, thinner needle to collect the fluid that drips out. Then we take the needle out, put the dressing on that stays on for usually about a day, and it can come off, and then resting afterwards. So what I would say is, just from my own experience of seeing people in clinic, key things to say beforehand is know which medications you're on or your relative is on. Bring a list with you, because we would not want to do this procedure on someone who is on a serious blood thinner, and by that I mean warfarin, or something called clopidogrel, which is similar to aspirin but it's used in people who'd had heart attacks or strokes. The reason being is that obviously you increase the risk of bleeding when you're shoving a needle into someone, and that would be the same for any operation. They'd need to know that you're on that. Baby dose aspirin, so 75 milligrams, is usually absolutely fine. We don't stop that beforehand. But warfarin and clopidogrel. If anyone's on any immunosuppressants, by that I mean steroids or more heavy-duty things like chemotherapy, I always like to know that. We're always very clean when we do this, but you are at high risk of infections if you have an invasive procedure, so I always ask people that. And other conditions, so usually most people have had a brain scan by the time they've had this, so I always check the brain scan. If someone's got a large tumour in their brain, the pressure is higher, I wouldn't want to do this without speaking to a neurosurgeon or a radiologist to check that it's safe. But dementia in itself, having brain atrophy or shrinkage, is not a contraindication to having this procedure. Bring someone with you, because it's quite boring lying there for an hour, and it's nice to have someone who knows you well for reassurance, and I encourage people to talk to each other if they want. Some people don't want to, they just want to have a nap. Some people fall asleep during it, but it is nice to have someone there. It's really important, you can eat and drink, it's not like an operation, you can have breakfast on the day. It's important to drink enough water, because there is a higher risk of headaches in people who are dehydrated, because the pressure is slightly lower within the system if you haven't got enough fluid generally in the body. We found that caffeine can help with a headache, so coffee, tea and Coca-Cola. So about 10% of people get a headache afterwards, so 1 in 10. It's quite rare. It usually comes on within 1 to 2 days after the procedure and can last up to 7 to 10 days, but usually a couple of days. It's a low pressure headache, which means that it gets better when you lie flat and worse when you stand up. And most of it goes away by itself, but caffeine can help. And I've spoken about taking things easy. And again, that's about the headache as well. Any questions about the procedure, side effects, anything else at this stage? The risk, you talked about the risk of complications such as bleeding and infection and nerve damage are extremely low, and I'm talking less than 1 in 1,000, because we're going below the level of where the spinal cord finishes. There are some little nerve roots there, but the risk of damaging them is extremely low. People sometimes get a bit of backache because we're obviously putting a needle through the back, and that can be sore, but paracetamol helps. Okay, so that's how we do it, and this is why we're actually doing it, which is probably the slightly more interesting bit. So dementia, as I'm sure you'll know, is actually just an umbrella term for a condition that leads to progressive loss of brain cells over time and leads to progressive changes in thinking, behaviour and language. Within dementia, there are lots of different types. Obviously, you're here for FTD, but there are lots of other people, and so some people have other diagnoses here. So we're really trying to find out what kind of dementia someone has, because that alters what treatment we give. Particularly if someone has Alzheimer's disease, there are some specific medications that have shown to be effective for symptoms in Alzheimer's disease. So when we're assessing someone who comes to our clinic, we want to know what's the story, what's been happening over the last few months or years. We might do some memory and thinking tests to see what pattern of problems there are. Is it judgment? Is it calculation? Is it memory that's been affected? Vast majority of people should have an MRI scan unless they've got something like a pacemaker, which the magnet can't deal with, and they would have to have a CT scan. Not everyone has to have a lumbar puncture though, and there are specific groups of people we do this in. So first of all, if we think there might be another cause, so it's recently developed, and there are other things that are unusual, we want to make sure there's nothing else that we're missing that we can treat. So specifically infection, although I have to say infections don't often lead to dementia-like things, but they can do. You can get some things like tuberculosis, TB, that are very, very rare, that over time can lead to thinking problems. Things like multiple sclerosis, we don't want to miss that because there are treatments, and obviously tumours and things, but hopefully that would have been picked up on the MRI scan. So when we're looking at the fluid, often people say, well, what are you actually sending this off for? You know, we come in for this big procedure, and we're told it's normal or abnormal, but what does that actually mean? Well, the basic things we look for in everyone are there any white blood cells, red blood cells, how many are there? So generally there should be no blood cells in the fluid. It's completely what we call acellular. It's very sterile, very clean. If there's infection or inflammation, then you get white blood cells there, and unless you've hit a little blood vessel on the way in, which can happen, you get some red blood cells in there in a brain hemorrhage. Protein levels are useful, and sugar levels, because they can go up and down in various conditions. Most people who don't have meningitis have no bugs, you'll be pleased to know, in their brain, so it should be completely free of any viruses or bacteria. And very rarely, if we think there's a blood cancer or lymphoma or leukemia, we check for cancer cells, or sometimes cancer cells spreading from another tumour somewhere else into the brain, but most people don't have any at all. So I'm moving now on to specifically for dementia, what do we look at? Well, as I said, we're trying to find out what type of dementia we have, and particularly if the diagnosis is uncertain. As Dr. Rohrer said, people don't fit neatly into boxes. People have symptoms of different types. Is it Alzheimer's? Is it dementia with Lewy bodies? Is it frontotemporal dementia? And that's really important. And in fact, in patients who are under 65, and we see a lot of patients at the National, the American Academy of Neurology guidelines say that a lumbar puncture should be performed in all patients under 65 for diagnosis of young onset dementia. So we tend to do them much more at our centre, where we see a lot of patients who have that. So, the current two markers that we look at, there are only two available really at the moment, and this has taken maybe 15 to 20 years of research to be able to get to this point. So this is why we do research, and it's ongoing. There's a protein that is normally in the brain called amyloid, we all have that, but in patients with Alzheimer's disease, I'll show you a picture in a second, it builds up and clumps together outside the cells. There are also proteins called tau and phosphotau, which is like a different version of that. And they are released by dying cells, and they also build up in tangles in Alzheimer's disease in the cells. So we're looking to see whether we can detect levels of those. And everyone has a normal level, and we're trying to see, are they too low, are they too high, what's going on with that. So this is a kind of very bad drawing of looking at some brain cells or neurons. And if you look on the left, the normal individual has the cells and some stuff in between, but the person on the right has these clumps of amyloid that have built up into plaques and can't be cleared, and they're starting to choke the cells, and that's why cells can't function, and then they end up dying off. Inside the cell, you also get these things called neurofibrillary tangles, which are basically tangles of this protein tau. Again, these shouldn't be there, and they choke the cell as well. So there's a two-pronged attack on the cell in Alzheimer's disease. And this is a real person's brain that's under the microscope, and you can see quite clearly here, there's massive brown plaques here, and this dark neuron here, which should look more like these, nice and light. This has got a build-up of these proteins in it. And that's what we're really looking for in the lumbar puncture, because amyloid gets stuck in the brain in these plaques, so it goes down in the fluid that bathes the brain. It should be floating around freely, but it gets stuck in the brain tissue and it goes down in the fluid. And the tau shouldn't be there at all, and it's just released when nerves die, and that goes up in the fluid. So when we're looking at different types of dementia in a healthy individual, these three markers are normal. They're normal levels, so they're at a certain number. In Alzheimer's disease, the amyloid goes down, as I mentioned, and these two go up because of dying cells. And in people who are just at the early stages of Alzheimer's, so what we call mild cognitive impairment, you get more subtle changes like this. So if we can actually start detecting people who are on the verge of developing Alzheimer's disease, and we'd like to be able to do that in other types of dementia, but currently in FTD, amyloid isn't one of the proteins that's really involved in typical FTD, so that doesn't change. But nerve cells do die, and they release tau, so you get a moderate elevation in tau and occasionally in phospho-tau. But there's no specific markers for FTD. This is where we are. We can only either say, yes, it's likely to be Alzheimer's disease because you've got a typical picture in the fluid, or no, they're normal, so it's something else. That's what we've got so far. And that's what we're trying to find from research. So what are we going to do about FTD or people with vascular dementia? What markers are we going to use to diagnose them, particularly if the scan is maybe borderline for one of the two? And that's very difficult because at the moment we don't have anything. So that's what I'm going to talk about next. I'm going to talk about why we're doing research into it. So these are the unanswered questions that as doctors and scientists we are trying to answer for you, and that's what people ask us. So what causes different types of dementias? Well, we know a little bit about it, but we'd like to understand the cause better to develop better treatments, because there are no curative treatments for any types of dementia at the moment. It's hard to predict what subtype of dementia you have. Even with FTD, there are lots of different proteins that build up, and the genetic ones are different from the sporadic ones or the familial ones. So we'd like to know what pathologies someone has in their brain. Sometimes people donate their brains for research after they've died, and as you saw from that picture, you can look down the microscope, and only then can we tell what type of FTD they have. But actually it's too late by then. We need to know that while they're alive or while they're developing it, so we can give treatments that might be developed in the future. Are we diagnosing it too late? Well, I'm sure most of you have gone through a very frustrating process of perhaps the wrong diagnosis or wasting ages or the misdiagnosis. So we want to get better markers that say this is the condition, this is what's happening, this is the stage we're at, this is why we need to intervene. It's also very difficult to predict when disease will start, particularly in patients who in some families carry the gene but we don't know when they're going to get it. Or sometimes patients' relatives ask us, well, how quickly will things change? How is it going to be in the future? Well, we can't give people an accurate picture of that at the moment. We can only say, and what I usually say is, things will probably progress at the same rate as they've already been progressing. So if someone's progressed quite slowly over the last 5 years, doesn't tend to accelerate, although there are obviously people who do differ from that. But what we really want is markers that predict when things are going to start, how it's going to change, and then we can measure over time if there are treatments that we can use in trials. So this graph, if I just take you through it very briefly, so when we see patients, particularly with certain Alzheimer's disease, we tend to see that at this stage they already have dementia. But there are people who are in this stage, mild cognitive impairment, who are on the verge of developing full-blown dementia, but not quite. And then there are lots of people who probably have these changes going on in their brains, but are completely asymptomatic, so they're completely fine. And there are probably a series of ordered changes that occur before people get symptoms, which is this round red line here. So perhaps there's build-up of proteins in the blood or the fluid, and then there might be changes on the scan, and then we can detect it on memory tests, and then you then do get symptoms. And we want to really be looking at this bit to see if we can detect it earlier. And that's what we're doing at the moment. So we think that the spinal fluid, because it's next to the brain, will be one of the first things to change, and that's what we're trying to do. Blood tests, although less invasive, really have not so far shown to reflect reliably any of these changes, and that's why fluid is important. So, someone who's now left mentioned that they were in GenFi, and these two studies at the Institute of Neurology at UCL, and I'm involved in the left-hand one, the genetic one, are looking at that over time. So the left-hand one is a study of patients with known gene mutations and their relatives who are also at risk, and the right-hand one is anyone else with FTD, so people who don't necessarily have a genetic cause, which is actually more common. And we basically we encourage people to come once a year for 3 years, and people can have a variety of different tests, and obviously all of these are optional, including the lumbar puncture, but most people have memory tests, an MRI brain scan, a blood test, some people have a lumbar puncture, and most people seem to be happy to have one, which is very kind of them, and then an examination and a picture of the back of the eye, because we're also looking into whether the retina shows changes. And really that's what we're trying to do, we study people and look at the fluid and see whether it correlates with things. So what I thought I'd do is just talk a little bit about the type of markers we want to look into, because some people have asked, well, what research are you actually doing? What, people have read things on forums that say, inflammation's the cause, or diet is the cause. Well, this is what we're looking at. So the first thing is these proteins that build up in nerve cells. So I mentioned tau, but some patients with FTD have a different protein called TDP43. So that could potentially tell us what's going on. Each nerve cell has a way of dealing with its own waste, like recycling and waste collection, and in some conditions we think that might be broken down, and things that normally are recycled or got rid of can't for some reason, and we're trying to measure that. We know that patients not only lose cells, but they also lose the connections between those cells that cause things and thinking to work, and they're called synapses, and there are proteins at synapses that might go up or down. And more recently, especially in FTD, there's a big drive to look at whether inflammation in the brain, so the immune system, is that too overactive. And there's been lots of evidence in Alzheimer's disease that that might be the case. But only recently have we started to look in FTD, because there have been gene mutations in progranulin, which are linked to inflammation and overinflammation, and there's more clues now that that might be a cause. So I'm just briefly at the end, this is nearly coming to the end, I'm just going to tell you a bit about my PhD and what I'm doing. And this is mainly for the benefit of people who are very kindly giving me their fluid, but it's also just to give you an idea of what's on the horizon coming forward. So, as I've said, the only way we can be absolutely sure someone's got a particular type of FTD or protein in FTD is to look at their brain after they've died. And some people have very kindly donated their brains to the Queen Square Brain Bank, as well as healthy individuals who've wanted to donate their brain. So we are looking for healthy people as well. And I'm basically slicing up the brains into very thin slices, putting them on a microscope slide and looking at inflammatory proteins or inflammatory cells in the brain to see if they are too active. If I find some proteins that are too active, and we are showing some signs of that already, we're going to look at those in spinal fluid, which I'm collecting from living patients in these two studies with FTD. We're also collecting them from children of patients with FTD who have the genetic mutations, so they are way before they develop symptoms, so to see over time, do they increase before they get symptoms. So we're going to do that in a large cohort of patients and healthy controls. We've got some control samples already, healthy individual samples, but we're already recruiting more people who are very happy to take part. And then what I'd like to do is, if there's some markers that we've found, we also have people having a brain scan and memory tests at the same time or around the same time of their lumbar puncture to see whether, does the rate of brain shrinkage match the change in these proteins? So could these proteins be a surrogate marker of how fast the disease is changing, the type of disease people have, and the underlying pathology? So we hope to find things that help us diagnose this disease better and earlier and more specifically for the type of thing. Once we've diagnosed someone, we also want to predict, how fast are things going to change? Are they changing? And in someone who might be at risk, are they developing the disease already and trying to intervene before they get too late for a treatment? And even when treatments are developed, we need to know whether they're working. And you can do memory tests, you can do brain scans, but brain scans, as Dr. Rohrer said, they don't really help that much. The kind of changes you need to see are quite big to be able to help us decide that. So, just to summarise, I've been through what a lumbar puncture is and how we do it, why we use it to diagnose dementias, and specifically that we can use it to help diagnose Alzheimer's disease, but also perhaps highlighted some of the things we don't know and what we're trying to find out. So if there's any questions, I'm happy to take them, but I've just written down two websites. The first one is the NHS UK website, which has some information about lumbar punctures if you wanted to direct other people to a reliable source of information. And the second one is our website talking about the research study. So if I know some people come because they've heard about it or they are interested, and so very welcome to look that up. Thank you very much. So sometimes patients with behavioural symptoms can have a different underlying protein in the brain. So specifically Alzheimer's disease, you can get a variant of Alzheimer's disease that causes prominent behavioural symptoms. It's called a frontal variant of Alzheimer's disease. So the memory tests are helpful to see, are there memory problems and other thinking problems. The scan might show if there's kind of changes in the front or the middle. But the lumbar puncture will probably be able to say, well, could it be Alzheimer's disease? So are these amyloid and tau proteins the correct way round for Alzheimer's disease? Because if they are, then it might suggest that actually some treatments like the donepezil and things might be helpful for him. Whereas if it's something else like dementia with Lewy bodies, then there are different treatments for that. If they're completely normal, the lumbar puncture, and it fits with most of the other type, you could probably say it's more likely to be FTD. As I said, you can never be 100% certain, but most patients who say, well, yes, this really fits with this condition. So that's why we use it. Yes? Yep, so in the last 10 years there has been an explosion of research. I can tell you in the last 4 months there's 2 new genes that have been found linked to FTD, and particularly FTD with motor neuron disease. So suddenly the rate of number of genes is increasing. The biggest gene that was in the last 10 years was found in 2011, and that was called C9orf72. And that's one of the 3 main genes linked to FTD. And that causes FTD alone, or just motor neuron disease alone, or both. And it's not clear why some people get a variety. Yeah, they're autosomal dominant, which means that if your parent has it, your biological child is at a 50-50 risk of having that. And if you have the gene, you will get the condition if you don't die of something else first. Of those types of genes, yeah. But you're right, there is a massive explosion. And unfortunately, despite us knowing about some of these genes, like progranulin and tau, since around 2006, we still don't understand why they cause the disease. And that's what this research is looking into. So progranulin mutations, we know progranulin protein, when it's working in its right self, is linked to inflammation, it's linked to cell growth, but why that, when it's not working, it causes the disease, we don't understand. But you're right, it's quite difficult to say to people, well, we haven't found any genetic cause so far, but there's a strong family history, and there's a possibility that you have a gene in your family that we don't know about yet, and that's why research continues to look at large numbers of studies of people, which is quite difficult in FTD because it's quite a rare condition, but we're trying. Yeah, they're very rare, so probably less than 1% of the cohorts they're being found in. There's a gene called TBK1, and there's another gene called CCNF, which has come out. So it's constantly having to keep up on top of the field, but once we see a gene that's come forward, like TBK1, we have what's called a dementia panel, so a genetic panel for, on a research basis, we put all our blood samples for research patients through. And I know that Professor Mead, who's in charge of the genetics, is adding TBK1 onto that panel, so that we then go back over all the samples we've collected over the years and recheck everyone for that gene, because we could find a few people. It's rare, it's a rare gene, but we could find a few people who have that. So that's a really good question. So in Huntington's disease, which we've known about the gene far longer than the FTD genes, at UCL there is currently a trial of gene therapy being given through the spinal fluid route in patients with Huntington's disease. So they are giving a protein that binds to that faulty copy of the gene and blocks it. And that's what we'd like to get to for some of the other genes. So this C9orf72 gene is a similar kind of problem. In America, where they have much larger cohorts of people, they're starting to develop in mice and other basic levels. They're trying to develop an anti-gene therapy for that mutation, but we're quite far away from that. You know, we're a good 5 years, I'd say, away from it being used in actual clinical trials here or even in the USA. But we're getting there. And we are trying to look at drugs that help raise or lower the gene levels or protein levels, like progranulin. One of the clinical trials we're running here looks at trying to boost and replace progranulin levels in people who have that mutation. So there are lots of different approaches you could use. The reason we're excited about inflammation is that there are lots of anti-inflammatory drugs already out there on the market that we know are safe, that are used in rheumatoid arthritis, psoriasis. So if we could say, yes, there's definitely an indication this might worsen the disease, or at least it'll cause it, that might pave the way for more clinical trials in this condition. But at the moment we don't have enough evidence to support use of those yet.
Really fantastic, thank you. I was kind of hooked all the way through, and you were brilliant, really brilliant presentation. Thank you so much. And I want really to bring our official meeting to a close. Obviously we're a little bit ahead of schedule, which is unusual, but do feel free to make use of the room and the venue for as long as you like. We've been relatively spared the usual noise of being in the midst of UCL. I think it's exam time, and so people are either studying or in exams, so we've had a bit more peace than usual. But I am hopeful that come the autumn we will move the venues for our meetings to the Wellcome Institute on the Euston Road, where we're very fortunate to have been, well, we've won residency at the Wellcome Institute for 2 years in the first instance. So we'll have the whole of the 5th floor of the Wellcome Institute, and that space will be dedicated to become a dementia hub. And yeah, we really look forward to sort of seeing how that develops, and certainly our support group meetings can start taking place there as of October this year. And the reason I keep glancing at Emily is because Emily is going to be taking time out to kind of coordinate the setup of the dementia hub over at the Wellcome Institute. So that's a really exciting development and sort of opportunity for public engagement and for the support groups to kind of have a platform within that. So as ever, I thank you for coming today, and I thank you for your time and for your willingness to share so openly about circumstances that are incredibly personal to you, and to share them in a forum such as this is hugely helpful, not just for the people in this room, but obviously wider than that when the discussions that we have are published online and sort of made available to people who for all sorts of reasons can't be with us at a venue like this today. So I wish you well, safe journeys home. If there's anything that we can follow up on as a result of today, don't hesitate to email, and we'll definitely clarify. Otherwise, our next official FTD meeting is September during FTD Awareness Week. That will be published in the newsletter which we've just circulated, and we have various other joint meetings and PPA meetings scheduled throughout the summer. So look online for the dates of all of those. But otherwise, thank you, and yeah, as I say, safe journey. Thank you.